Hello there, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. We shall today discuss massive transfusion protocol, and massive transfusion associated reactions and complications. Please keep your notebook ready. Okay, and at the end, please subscribe to our channel and give us a like if you find the lesson useful. So let us not waste time anymore and start right now. Massive hemorrhage is a common complication in a number of clinical settings. It is responsible for almost 50% of the deaths occurring within 24 hours of injury and up to 80% of the intraoperative trauma deaths. Massive blood loss is seen in various situations like polytrauma, major surgeries, gastrointestinal bleeds, postpartum hemorrhage, and other situations where there is severe bleeding. Massive transfusion is the only treatment for massive bleeding. It keeps the patient alive through volume and oxygen support while bleeding source control maneuvers such as surgery, endoscopy, uterine packing, or liver replacement are carried out. Massive transfusion is life saving, but there are associated risks and complications. In adults, what does a massive transfusion mean is the native blood volume replacement by transfusion of one total blood volume within 24 hours or transfusion of more than 10 units of whole blood or packed red blood cells PRBCs in 24 hours or transfusion of more than 4 units of PRBCs in 1 hour when ongoing bleed is expected, or transfusion of 50% of total blood volume within 3 hours, or transfusion of ongoing blood loss of more than 150 milliliters per minute, or transfusion of ongoing blood loss of more than 10% of total blood volume per minute. Data regarding massive blood transfusion in the pediatric population is scanty, but it is generally accepted as any transfusion of more than 40 ml per kilogram body weight in first 24 hours. Massive transfusion requires careful monitoring and coordination between the physician's team and the blood bank. A massive transfusion protocol should be used in any profusely bleeding patient in need of a massive transfusion. Many hospitals now have developed their own massive transfusion protocols. The primary indication for massive transfusion is any situation resulting in heavy acute blood loss with hemodynamic instability. Indications include but are not limited to bleeding due to polytrauma, major obstetrical hemorrhages such as postpartum hemorrhage, supramajor surgery, and catastrophic gastrointestinal bleedings. The decision of massive transfusion is guided by hemodynamic state of the patient, amount of blood loss, and potential for ongoing or future bleeding. There are no absolute contraindications for massive blood transfusion, but lack of adequate expertise and supplies is a relative contraindication. There are many challenges to massive transfusion, such as maintaining adequate hemostasis and preventing dilutional coagulopathy, avoiding hypocalcemia, hypothermia, acidosis, and potassium derangements, mostly hypokalemia, preventing usual transfusion reactions and infections, managing fluid overload or TACO, and lung dysfunction or TRALI. Goals of massive transfusion management should be early recognition of excessive blood loss and activation of massive transfusion protocol, maintaining tissue perfusion and oxygenation by restoring blood volume and hemoglobin, arresting source of bleeding through early surgical or radiological intervention, and judicious use of blood component therapy to arrest and correct coagulopathy. A protocol-based management of massively bleeding patients has shown improved outcomes and is known as Massive Transfusion Protocol or MTP. MTP should aim to interrupt the lethal triad of cat at hand, that is, coagulopathy, acidosis, and hypothermia or CAH, that complicates many massive transfusions. MTPs use a pre-formulated transfusion pack of packed RBCs or PRBCs, fresh frozen plasma or FFP, and platelets in a ratio of either 1:1:1 or 2:1:1. The former is most popular. The purpose of this strategy is to achieve hemostasis and increase blood volume with the minimal use of crystalloids. This balanced protocol helps avoid dilutional coagulopathy and further bleeding. Usually, at least 6 such units are required. Once the protocol is decided and activated, the blood bank ensures rapid and timely delivery of all blood components together to carry out the resuscitation. But unfortunately, until now, no one protocol has been standardized. The trigger for initiating the protocol, as well as the optimum ratio of PRBC, FFP, and platelets, is still debated. Therefore, protocols vary from center to center. The balanced transfusion approach cannot, however, correct the coagulopathy once developed. Therefore, the coagulation status should be monitored regularly, either with point of care testing such as thromboelastometry or with laboratory tests such as bicarbonate, potassium, calcium, fibrinogen, and clotting times. One should keep in mind that the MT protocol does not needlessly waste scarce resources. Criteria for stopping the MTP should be both anatomic, that is, control of bleeding, and physiologic, that is, a normalizing hemodynamic status. The MTP should be discontinued when there is recognition that any further resuscitation is futile. For pediatric population, there is no agreement on either the definition of massive transfusion or on criteria for initiating an MTP or the perfect ratio of blood components to be transfused. However, a general criterion for the initiation of MTP in pediatric patients is the need for transfusion of more than 40 milliliters per kg of blood products in the first 24 hours. A number of adjunctive strategies have been used either to augment a balanced transfusion approach or as alternative to blood component therapy but with variable success rate. Together with an appropriate and timely laboratory testing, this approach may correct the coagulopathy quickly, minimizing the requirement of blood transfusion and the ill effects of excessive bleeding and fibrinolysis. Agents used in this approach are antifibrinolytic agents such as epsilon aminocaproic acid and tranexamic acid, fibrinogen, prothrombin complex concentrates, and recombinant activated factor 7A. There are no fixed and simple criteria for initiating MTP. Initiating a massive transfusion protocol should be based on clinical observation and judgment considering the hemodynamic status of the patient. Also on the rate and volume of the current and predicted future bleeding, as well as on presence or absence of hemorrhagic shock. And please mind, the hemoglobin level may take hours to fall after bleeding. Therefore, hemoglobin estimation has little role in determining need for MTP, or at least it is misleading. Worsening hypotension and vasopressor requirement should prompt initiation of MTP. Point of care tests or visco-elastic assays such as thromboelastometry and sonoclot are available to monitor the coagulation status in a patient. These modern tests are used to guide therapy in a patient requiring massive blood transfusion by localizing the defect in the coagulation. Massive transfusion may result in complications like dilutional coagulopathy, metabolic acidosis, hyperkalemia, hypokalemia, citrate toxicity, hypocalcemia, hypothermia, transfusion associated circulatory overload or TACO, transfusion related acute lung injury or TRALI, and air embolism. Dilutional coagulopathy usually occurs due to initial resuscitation of a bleeding patient with excessive crystalloids such as Ringer's lactate and whole blood transfusion. It occurs due to loss of native blood, dilution factor, acidosis, and hypothermia, which destabilize the clotting complexes. Metabolic acidosis occurs due to the fact that more than 2 weeks old stored PRBC has a pH below 7 due to lactate accumulation. Acidosis directly undermines the activity of both coagulation pathways. Hyperkalemia and hypokalemia both may occur, but hypokalemia is more common due to potassium ion shift into the red cells from citrate toxicity and due to urinary losses. Hyperkalemia is rarely of clinical significance in this setting, apart from during neonatal exchange transfusions. Citrate toxicity and hypocalcemia can occur because high concentration of citrate in stored blood chelates the calcium, resulting in hypocalcemia. Hypothermia can occur due to administration of cold blood and blood products, opening of coelomic cavities, and failing thermoregulatory mechanisms from brain hypoperfusion. Hypothermia aids to the development of coagulopathy. Transfusion associated circulatory overload or TACO may occur due to blood and fluid overload causing non cardiogenic pulmonary edema. Transfusion related acute lung injury or TRALI resulting in acute respiratory distress syndrome is a lethal complication caused by antibodies or inflammatory mediators in the blood products. TRALI is regarded as the most common cause of death as a consequence of massive blood transfusion. Air embolism or air bubbles in the bloodstream result from improper infusion technique causing chest pain, dyspnea, hypotension, and cardiac arrest.